Thousands are raving about our best-selling 100 patient scenario book, and so we started creating the expansion books to go along with it, including the cardiac arrest scenarios, we have the airway scenarios, pediatric scenarios, and the MCI scenarios. And you can get this entire bundle at the link in our bio. This is Master Medics. Master Medics is an online learning tool made specifically for EMT and paramedic students. We've had 10,000 students come through us to transfer this textbook knowledge into their minds. And it works because it's fun, it's visual, and it's engaging. And if you want to try it out for yourself, you can start a 3-day free trial right now at the link below. Good. Okay. GI bleeds. Now, GI bleeds are fairly interesting. They're a fairly common call. So I'm sure that if you've been on ambulance for any given time, you've probably dealt with some GI bleed before. And that's, it's an interesting case and something that we do need to be aware of. This is not one of those patients where you can just pick them up, put them in the ambulance and go. There's actually things that we can do in order to benefit this patient. And so let's get into this case. Okay. Keep in mind that we do have a premium subscription. We have people that are watching right now that are not watching on social media. They are getting emails and getting notifications and coming to our private room to watch our classes, and you can do that as well. They also get the opportunity of getting continuing education credits for our cases, and so that is something that you can be part of as well. And so if you're a student and you're struggling in school, that's our bread and butter. That is what we do. We work with students that are struggling in school and need help, and you can certainly do that at the link in our bio and get started for free. And if you want continuing education credits, we do that as well. And if you want the credits for these cases that you're showing up for, that is an ability. You have the ability to do that as a subscription member as well. So check that out. We would love to see you there. Okay. Let's talk about today's case. You're dispatched to a private residence for a male patient with abdominal pain. You arrive on scene to find the patient, who appears to be fatigued, breathing heavy, and you also notice that there's a dark, foul-smelling diarrhea in the toilet. Okay, and there's your patient's presentation. Leaning over, there's the presentation of the diarrhea. So quite red, quite dark, not good. So this is pretty indicative of that GI bleed. I don't think that anyone was surprised about that or concerned about that, but that is what you've got. Now we're going to look at the vital signs here at a little bit kind of a little bit enlarged so you can kind of see. But the heart rate itself is 144, blood pressure 78 on 49 with a MAP of 58. Breathing rate is 24, SpO2 right now is 94%, pretty poor pleth, like not a great. It's kind of showing some poor perfusion in that pleth wave. So we have some things that we need to be concerned about, and that kind of correlates with that blood pressure there. So my first question to you all is, judging by these vital signs, and the question that I asked earlier today is this patient in a compensated or a decompensated state of shock? Go ahead, put that in the comments. Is this a patient in a compensated or decompensated state of shock? What do y'all think? Joe's thinking decompensated, decompensated. Faith's thinking decompensated. Decomp. A couple of people are saying compensated. Let's see what everyone on Facebook's thinking. Decompensated. Rosanna's thinking decompensated. Can't spell, but she thinks decompensated. Okay, so I agree with you. I think this is a decompensated state of shock. The reason being is that if you look at the heart rate, it's 144. The breathing rate, again, is a very good sign of a compensation factor. So with the breathing rate up and the heart rate up, this patient is compensating for shock, okay? So they have some sort of shock. So we know that compensation factors have kicked in. The next question you have to ask yourself after you've noticed that compensation factors have kicked in, you have to ask yourself, are they working? What is the best way to determine if your compensation factors are working? Well, shock is all about perfusion. The best indication of perfusion or flow is your blood pressure. And right now we have a blood pressure of 78 on 49 with a MAP of 68. So we have compensation factors that have kicked in. However, this patient is decompensating now regardless of if they have compensation. Okay? Their compensation factors are not working. And so if this was an exam question, this patient is textbook for decompensated state of shock. Okay, decompensated state of shock. Okay, so I'm not going to get too in depth of the physiology here because when it comes to doing your jobs as paramedics, there's not a huge importance of understanding a lot of what's going in from the pathophysiology, but I'm still going to go into a little bit because I think pathophysiology is important. Okay, textbook-wise, there's two different variations of GI bleeds. There's upper GI bleeds and lower GI bleeds. Okay, can they be a mix of both? Absolutely. Okay, so or can you indiscern them? Absolutely. Typically, textbook-wise, if it's a lower GI bleed below the ligament of Treitz, then you would have yourself a lower GI bleed if you had bright red stools. If, however, you have dark, tarry, melena-looking stools, that is more likely a upper GI bleed. Not esophageal high, but upper intestinal bleed. Why is that? Well, because of the digestion of the red blood cells. So if we have physical digestion of red blood cells because of this bleed, that creates that dark, stringy, tarry stool. Okay? In this particular case, we kind of gave a very indistinct we had a bright red looking blood. We also had a description of a foul smelling brown, dark blood or dark diarrhea. So we had kind of a mixture of both in this particular situation. In GI bleeds from a pre-hospital setting, it doesn't really matter if it's an upper GI bleed or a lower GI bleed. They're essentially going to be treated very similar from our perspective. Okay, so one thing I do want to mention, in GI bleeds, specifically lower GI bleeds, 30% of them happen because of outpouchings that are happening in the descending colon. So in other words, diverticulitis. Okay? So, we know this guy's having GI bleed. Now let's focus on the shock. Okay, we know they're decompensated, so it's important for us to treat this patient. We know what type of shock they are in. So, judging by the presentation, judging by the diagnosis, and the vital signs, what type of shock is this patient technically in? Go ahead, put that in the comments. What type of shock is this patient in? Hemorrhagic. What is hemorrhagic? What's hemorrhagic shock? Like, what's the true form of that? This patient is in what we would call a hypovolemic shock or a low volume shock. In other words, they can be treated very similar to how you would treat a patient that had a significant blood loss due to trauma. Okay? The only problem is that this bleeding is internal, so we cannot do a whole lot of tamponade in order to stop it. What we can do is hopefully keep them from progressing to a further state of decompensated hypovolemic shock. So now that we know that they are in a decompensated state of shock, we know that they are in a hypovolemic state of shock, and knowing what we know about hypovolemic states of shock and blood loss, what are some treatments that we can do in order to buy this patient time? Okay, maybe not stop the bleed because that's not going to be possible in this situation, but what can we do to buy this patient time? Okay, Ray's thinking fluid replacement, IV fluids, IV access TXA, we'll talk about that. What are you thinking on Instagram? Bolus, plug it up. Yeah, unfortunately not possible. O2, fluids, normal saline, keep warm fluids, like that. If you got to give fluids, be ideal if they are warm. Epi drip, interesting. Diesel, yeah. Okay, so based on what we have here, octreotide, okay, possibly in a critical care setting, but typically not on a ground ambulance. But I like your thinking is that you're thinking of what could hopefully stem some of that that blooding or blood direction, and octreotide might be able to do that. So let's talk about the hypovolemic state, okay, and what treatments that we can do for them. Well, as far as BLS things go, okay, hypovolemic patients should get oxygen. Okay, does it help? Yes, a little bit. And the reality is that this patient is fatigued. They're in a decompensated state of shock. The least we can do is increase the oxygen concentrations in their red blood cells that they still have in circulation. So is oxygen an important first thing to do in this patient? I would say yes. Okay, so first off, oxygen. The next thing is try and buy this patient time. Now, you probably know my position with isotonic fluids, and now that we know this is a lot like a hemorrhagic shock that we would see with trauma, the principles of isotonic fluids in blood loss are still the same regardless of what's bleeding. Is that over diluting blood is not beneficial for patients. Okay, so if we have isotonic fluids and we're going to resuscitate them with isotonic fluids, the goal is to keep them at a permissive hypotensive state, which is a targeting systolic of 90 or ideally a MAP of 65, and not increasing it any further than that. Okay, so that would be your isotonic fluids You can introduce them, absolutely. Ideally warm IV fluids, which was mentioned already in the chat. But the key point here is making sure that we follow the understanding of how hemorrhagic shock or ice or hypovolemic shock works, is that we don't want to over infuse isotonic fluids. We just want to use it to buy this patient time until they can get to blood products. Which leads me to my next point, is does this patient require blood? Okay, do you think that they're at a state right now that tells us that they require blood? Go ahead, put that in the comments. We're going to talk a little bit about pressors and TXA as well. But let's answer this question first. Does this patient require blood? What's their hemoglobin result? Fantastic question. Unfortunately, in EMS, we wouldn't have that ability to check it, but I'm going to talk about something else that we can use. We can use, whoa, that's not what I wanted. We can use the rules of 30s. Now, typically we use this in a postpartum hemorrhage shock, is the rules of 30, but they still apply in these cases as well, where we would determine, did they have a 30% fall in hematocrit? Not something we typically can check in EMS, but something we can check at the hospital or in a critical care setting when you have an ISTAT. What about a 30% fall in hemoglobin? Again, not something that we can check in the EMS setting, but something we can check in a hospital or ISTAT setting. But these two we certainly can. Did they have a 30-point decrease in systolic blood pressure? Well, their blood pressure was, what, 78? I think it's safe to assume that their baseline is minimum 110. And if they had a minimum 110, they have lost a 30-point decrease in their systolic pressure. Okay? They probably lost more like 40 to 45, maybe even 50, depending on what their baseline blood pressure is. But even if we're safely to assume that they had a lower to normal blood pressure at 110 systolic, at 78 systolic, that's a 30-point decrease. Okay, 32. Did they have a 30-point increase in their heart rate? Well, again, a normal heart rate is, let's say, at the highest, 100. Okay, at the highest of normal of 100. His heart rate is 144. So he is 44 points above even the highest heart rate. So judging by just these 2 points, I think from an EMS perspective, we have enough evidence to suggest that there is a high likelihood that this patient does get blood products when he arrives at the hospital, or if you can get a unit to arrive with blood products, that would be ideal. The faster and earlier you start them, the better it is for these patients. Sorry, I'm going to just focus it up a bit. There you go. Okay, so let's fall back to the questions that you had about a couple other things. And that is, well, if we don't want to use isotonic fluids, should we look at using pressors in order to increase the blood pressure instead of fluids to buy us time before blood has arrived? There's been some studies that haven't shown a whole lot of great promise in that regard. So should we do it? Probably not, until we have a better idea of the benefit of it. Okay, so as far as pressors go, there hasn't been any evidence to suggest improvement in mortality when using pressors in hypovolemic shock. Okay, so that's probably out until more evidence and more studies are done to prove it. In theory, it makes sense, but it doesn't really make a ton of sense to squeeze a chamber or squeeze the vessels tight when there's no fluid in them anyways, right? So there is some back and forth on if it makes sense. But as far as we know right now, the mortality has not improved with patients that, that didn't get them. The next point was, what about TXA? It's a bleed. Should we be using TXA? there was a study that was done in hospital. I want to pull that asterisk out and say it was done in hospital after a confirmed GI bleed. Okay, so knowing that little information, confirmed GI bleed, had to wait till we had a confirmed GI bleed to give TXA. What is the one thing that we know about TXA? The one thing that we know about TXA, the better it is, has its more efficacy, the better it is, the earlier it is. So giving it in a GI bleed patient after you've confirmed by scope or whatever, or some sort of diagnostic in order to confirm they have a GI bleed, this is hours after it started. So yeah, I'm not surprised that TXA did not have a benefit with those patients. But I digress. There hasn't been a study to show TXA's efficacy in GI bleeds at point of EMS. When we have it, will it be a benefit? Hard to say, because we don't know when that GI bleed started, which also is a factor. The nice thing about trauma is that we can pinpoint exactly when the bleed started. So why not so we can give TXA early. In GI bleeds, typically we're behind the 8 ball on the bleeding because it started not that day or that hour. So is TXA going to be a big benefit in GI bleeds ever? It's hard to say. My money is on probably not. Okay, so that's a little bit about a couple of those things, but the key points that you guys need to focus on is 1, identifying the GI bleed, 2, identifying are they in a compensated or decompensated state of shock, and finally, isotonic fluids to maintain a systolic pressure of 90 or a MAP of 65, no more. Get them to the hospital or get them to some sort of ability to introduce blood. And that is how you're going to be treating these GI bleed patients in an EMS setting. Any questions with that? Go ahead, put them in the comments. Was that Haltit study the one I'm talking about, or is that an EMS specific one? Adrian. I'm interested. Maintain peripheral pulses, sure. What about epi-drip for maintaining a BP? That would be kind of my discussion about pressors, is that there wasn't a whole lot of evidence to suggest that it was a benefit. I believe the study looked more at norepinephrine than epinephrine. I could be wrong about that. I'd have to reread that study. Calcium gluconate, only if the calcium's low. Thermal management, absolutely. Cold patients are not a benefit. This is a true hypovolemic patient, so cold patients, not a benefit. Can you explain the TXA point again? Sure. So think of it this way, is that what we know about TXA is that it is most beneficial in patients when it's given early. So why isn't it not a benefit in patients with GI bleeds? Is because it's hard to pinpoint when the bleed started. And so we don't know if we're giving it early. And in the study that I was referencing, the TXA was given hours later once they confirmed a GI bleed, which is even further down the line. That's what I was saying. And so TXA is a benefit if it's given early by EMS. Okay, and that is only really what we know about trauma-related TXA. And even the benefits, and then postpartum hemorrhage. There is a benefit in TXA there. That's the one that we're really holding on to, is that there's a huge benefit in TXA and postpartum hemorrhage. If you look at a lot of the evidence around TXA in trauma, it's kind of like, it's marginally better. Statistically better, but marginally. What's the max you would bolus isotonic fluid before blood products? I would give as little fluids as I possibly could to maintain a systolic pressure of 90 or a MAP of 65, and then introduce blood as early as I possibly can. So I can't really say how much. It's just about how little can I give them by maintaining and still maintain our kind of hard lines of pressure or perfusion. Okay. Ringers would be fine, yeah. Do we use octreotide in a critical care setting? Yes. So we use panto and octreotide for GI bleeds. So those are something that we can use. I elected to not talk about them too much here because that's something that we use in critical care and for more longer term transports that I do. It's not something that's really seen in EMS from a ground perspective, which is why I elected to leave it out. But yes, when they get to the hospital, common medications to give for GI bleeds is octreotide and sometimes Pantoloc, depending on the location of the bleed. Okay. Well, I don't see anything else out there, so I think I'll leave you there with that. If you do have any questions, please feel free to throw them in the comments after this video, or if you missed it, we do post them on our Master Medics membership. You can check that out for free if you want to rewatch this, and if you want to get credits for these types of courses, this one included, you can still get credits for these classes. We make interactive videos of these, so that way you can get an hour credit for this particular class after you do a short quiz. And again, we have these for dozens and dozens of other of our case classes as well. So hopefully you'll check that out. And if you ever have any questions at all, please feel free to reach out, and we'll see you next time. Bye for now.